Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on today's program. Today's program is from our physical exam series, and it's entitled Special Tests in the Chiropractic Examination of the Spine. Now, as chiropractors, we know that there are many different types of spinal conditions that present to us in our clinical practice. Well, of all the different conditions, including sprains, strains, subluxations, dislocations, contusions, and all these acceleration and deceleration syndromes, of all the conditions that present in the chiropractor's office, I want to limit our discussion in today's program to just two conditions. That is, conditions of radiculopathy and myelopathy. And as chiropractors, we know that we get fabulous results with the treatment of both of these conditions. Both radiculopathy and myelopathy respond well to chiropractic treatment procedures. However, that secret seems to be well kept within the chiropractic profession, and I want to share with you what some recent authors have stated about the efficacy of spinal manipulation in the treatment of radiculopathy. So it seems that the secret of the success of chiropractic spinal manipulation in the treatment of radiculopathy is not yet out, and that's an area where we as chiropractors need to do much better. So I'll share with you what some recent studies have to say about spinal manipulation. But before we get to that, I just want you to know that this is going to be the most complete course on radiculopathy and myelopathy that you've ever had. All in one place in the course of 6 hours, we're going to go over many aspects of the physical examination and the diagnostic study findings for both radiculopathy and myelopathy. Now, by definition, radiculopathy refers to injury to one or more spinal nerve roots, whereas myelopathy refers to injury to the spinal cord itself. So in this program, we're going to talk about how radiculopathy and how myelopathy can manifest depending upon which part of the spine the problem arises. So radiculopathy and myelopathy will have one set of presentations in the cervical spine and a different set of presentations in the thoracic and lumbar spine. And we'll talk about those various presentations as well as the physical examination findings associated with both of those conditions. So with regards to chiropractic and spinal manipulation as it's described in the literature, I just want to read for you some brief passages from a recent study published in the Current Review of Musculoskeletal Medicine. And this is a 2016 study related to cervical radiculopathy, and it has to do with cervical injuries and treatment. So this is an article that discusses all about cervical radiculopathy. Well, they talk about some of the treatment modalities that are described in the literature regarding cervical radiculopathy, and they talk about non-operative treatments such as immobilization, such as physical therapy, such as traction, such as manipulation, such as medication, such as corticosteroid injections, and then they go on to the operative forms of treatment. So very briefly, let me just review what they have to say regarding manipulation and the treatment of radiculopathy. So they tell us that recently a certain author performed a Cochrane review examining the effect of manipulation and mobilization as a treatment modality for neck pain. These authors generally found that the literature in this area was of low to very low quality. So that's something as a chiropractic profession where we need to improve the quality of our research to support our claims for the efficacy of chiropractic spinal manipulation in the treatment of neck pain conditions, including radiculopathy. So they criticize our research right off the bat as being of low to very low quality. However, these studies, even though they were low and very low quality, they showed improved immediate pain with manipulation compared to immobilization, and they showed that repeated manipulations might provide some benefit. So that's good. However, these authors were able to find no benefit for manipulation at short-term and intermediate follow-up. And I personally know that to be incorrect. In my clinical experience, nearly 100% of patients respond, both short and intermediate term, positively. They respond positively to spinal manipulation. Additionally, when manipulation was compared to mobilization and physical therapy, there were no differences in outcome at immediate, short-term, and intermediate follow-up. The uncertain benefits provided by manipulation must be considered in the context of the potential for catastrophic complications that exist with cervical manipulation. And here they finish this paragraph by talking about the dire consequences associated with dissecting vertebral artery injuries. And this represents quite well the dilemma that we face out in the healthcare marketplace with regards to chiropractic spinal manipulation and neck pain conditions. It seems that the efficacy of the treatment is not well established, and the harms and the potential adverse consequences, even though they're extremely rare, as you know, vertebral artery injuries are extremely rare. However, they continue to be raised in the literature as a source of contraindication for spinal manipulation. So this represents some of the dilemmas that we face in chiropractic in getting the efficacy of the treatments that we perform established in the marketplace and in the literature. So in today's program, we're going to go over many aspects of radiculopathy and myelopathy, and by the end of this program, your confidence and your ability to handle these conditions within your clinical practice is going to be greatly enhanced. So, with no further ado, I'd like to begin today's discussion: chiropractic special tests in the spinal examination.
Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on today's program, which is entitled Special Tests in the Chiropractic Spinal Examination. And today's program is approved by the Board of Chiropractic Examiners for 6 hours of home study continuing education credits. And if you're not familiar with the board's requirements, the board requires that you complete at least 6 hours under what they call Category A. Now, within Category A, you must complete at least 2 hours in ethics and law. And the remaining 4 hours can be completed in any one or any combination of the following subject categories: history taking and physical exam procedures, or chiropractic adjustive techniques, or chiropractic manipulation techniques, or ethical billing and coding. And today's program satisfies 6 hours, 2 extra hours in the history taking and physical exam procedures. So today's program, when combined with 2 hours of ethics and law, more than satisfies your Category A requirements, and those 2 additional hours could spill over into any of the other 2 categories to contribute toward your total requirement of 24 total CEU hours. So you're in good shape with today's program. Today's program is a narrated PowerPoint presentation. It's presented just as if you were at a live lecture, and the PowerPoint is going to unfold right in front of you. With my voice narration and pre-recorded slides unfolding, really just like as if you were at a live lecture. And the PowerPoint presentation is enhanced with many different multimedia enhancements, including video demonstrations and links to YouTube citations and internet links. And so the preferred method of viewing today's program is with PowerPoint, because the PowerPoint contains live links and live animations and live multimedia enhancements. If you do not have the PowerPoint, you can still enjoy the program, because your course materials include copies of the PowerPoint slides, and on those copies I've included space for note taking. So regardless as to whether you're watching this on PowerPoint or you're simply listening to the audio program and referencing your handout materials, you're going to want to get your handout materials with you right now so that you're ready with all your materials to participate in the presentation. So when you are ready and you have all your materials together, I invite you to join me here on the program. Sit back and relax and take notes and simply enjoy the program as it unfolds in front of you here. I want to introduce myself to you. My name is Perry Carpenter. As I said, I'm a chiropractor. I've been a chiropractor for over 27 years. And it's my pleasure to be with you today. I'm bringing you what I consider to be some of the most relevant and interesting topics, the purpose of which are to help you become a better doctor and a better evaluator and a better technician in the physical examination room. And today's procedures are all about physical examination procedures. I want you to know that we have a growing library of topics that are relevant to not just chiropractors, but also fitness professionals and qualified medical evaluators. And so I encourage you to check our website often for new program releases that may be of interest to you. And also I want to ask you for a favor. If there's a topic that interests you or some particular content area that you are intrigued or fascinated by, I'd like to hear about it. It's possible that I might create a program just on that very topic. And in fact, today's program is the result of a suggestion by one of my subscribers on our Qualified Medical Evaluator website. So I do take suggestions seriously, and I encourage you to drop me a note if there's something that you'd like to have me explore for you. For those of you who are also qualified medical evaluators, I want to let you know that we have an entire website full of continuing education programs just for you. And I've listed for you here on this page our website for qualified medical evaluators, which is ezqmeceu.com. And I'd like to have you take a look at the titles that I have listed here on this slide or on your handout materials. Each one of these titles is a live link to an introductory video for each of these programs, and each of these programs qualify for both Board of Chiropractic Examiners and also Division of Workers' Compensation continuing education credits. So if you're a chiropractic QME, you may be interested in these programs because they provide double credits. They give you credits for both your Board of Chiropractic Examiners and also the Division of Workers' Compensation. And many of these courses, certainly this manual muscle testing course and the importance of the neurologic examination course, those are both Category A physical examination courses. So my point is that by using these programs, you can sometimes get 2 and 3 bangs for your same buck spent by satisfying mandatory requirements in several different categories. So I encourage you to check our website and check this particular website here if you are a qualified medical evaluator. So what about today's program? Well, today's program is entitled Special Tests in the Chiropractic Spinal Examination, and the references for today's program include the following. Includes the AMA Guides 5th edition, includes the Bates Physical Examination 10th edition, includes the Technique of the Neurologic Exam textbook by DeMeyer, MD, and also when we get into later parts of the program, I'll be referencing Yoakum and Rowe's Essentials of Skeletal Radiology 3rd edition. And today's program is going to be divided into 2 parts. The first part is all about the physical examination, and we're going to focus our physical examination on the cervical spine, the thoracic spine, and the lumbar spine. And I know you're thinking, well, that's a pretty broad topic, but we're going to narrow our focus down to just a few select conditions, which I'll describe here in just a moment. And then when we get into part 2 of the program, we're going to go into then special tests in the spinal radiographic examination. So part 1 is about the spinal physical examination. Part 2 is going to be about the spinal radiographic examination. And again, we're going to limit our focus to just a couple of topic areas. Specifically, we're going to focus on determinations of spinal stability versus instability. And I'm going to take you step by step through a procedure of performing an analysis of intersegmental spinal motion and a determination of spinal instability. And this is material directly out of the AMA Guides. If you're a qualified medical evaluator, you'll recognize that this comes out of the AMA Guides. If you're not a qualified medical evaluator, I mention this here because the method that is described in the AMA Guides is a very valuable and useful method to learn. It's not the only method that there is for determination of spinal instability or instability. In fact, there are many methods. I spent many years before learning about the AMA Guides. I used Penning's method. And even that is not the only method, but the method that's described in the AMA Guides is very simple to perform, not cumbersome like Penning's method, which required all these gymnastics and gyrations to do. This is a very easy method to perform, and it's very well documented, and it's referenced. I mean, it comes out of the AMA Guides, so there's not much stronger reference that we can get. So we'll go through that, and then we'll get into some material regarding compression fractures. Again, compression fractures of the cervical spine, thoracic spine, and the lumbar spine. So let's dig in a little bit. Now, as I said, I've been a practicing chiropractor for 27 years, and you know, that's actually approaching 30 years, and I don't know how many years you've been in practice, either fewer years, the same years, or possibly even more years. And I'm sure you'll agree with me that you know, there are many different types of conditions now that present themselves to a chiropractic office. Well, if we limit our focus just to those conditions that come in to us that are related to the spine, again, the list is very large. For example, we see spinal sprain cases. We see spinal muscular strain cases. We see facet syndrome cases with facet syndromes in the cervical spine and the lumbar spine, and we see spondylolisthesis cases and subluxation cases and transitional vertebra cases and all types of different anomalies of the spine, and all these different conditions present to a chiropractic office. But in today's program, we're just going to limit our focus to 2 main conditions, and that is number 1, radiculopathy, and number 2, myelopathy. And we're going to focus on these 2 conditions because these are 2 topic areas that could potentially suggest serious injury, and injury that could have a poor prognosis if not properly identified, properly diagnosed, and then of course properly treated. So today's whole program is about special tests for the determination of the presence or absence of either radiculopathy and or myelopathy. So let's define these terms. Radiculopathy refers to injury to the spinal nerve roots. Radiculopathy is injury to the spinal nerve roots. Myelopathy, on the other hand, is injury to the spinal cord. So they both involve injury to neural tissue around the spine and around the spinal cord. Myelopathy is a direct injury to the spinal cord itself, and of course that can carry with it a whole constellation of symptoms, both local and distant. And radiculopathy is injury to the exiting spinal nerve roots, which can also carry with it a constellation of symptoms, both locally and also distally or distant. Now, a couple of different terms that you might see in the literature or in medical reports that you read refer to different types of causes of myelopathy. A traumatic injury to the spinal cord is simply called a traumatic myelopathy, and that's what Christopher Reeves had, correct? When he fell off of his horse, he had a high cervical spine injury, so he developed traumatic myelopathy. Myelopathy can be due to inflammatory disorders, in which case is referred to as myelitis. Sometimes you might see the term spinal myelitis. And with vascular injury to the spinal cord, we refer to that as vascular myelopathy. So let's go in now to the topics of radiculopathy and myelopathy and define those conditions and consider some statistics and physical presentations of these conditions, and then we'll get into the physical examination maneuvers for each of these conditions. Okay, so a couple of statistics first about radiculopathy, and this is out of the 2010 statistics published by the Agency for Healthcare Research and Quality. They stated that cervical radiculopathy is less prevalent in the United States than lumbar radiculopathy, with an occurrence of approximately 8 cases per 100,000 patient presentations to physicians' offices. Okay, per 100,000 patient presentations to doctors' offices, cervical radiculopathy accounted for only 8 cases. Now, we all know that the most common presentation to physicians' office is the upper respiratory infections, and then followed closely thereafter by low back pain. Cervical radiculopathy, much less frequent. However, it's my opinion and my contention here in today's program that as chiropractors, we are much more inclined to see cases of cervical radiculopathy than our family health care practitioners or primary care providers. And so in a chiropractic office, you can expect to see cervical radiculopathy cases much more often than 8 cases per 100,000 visits. It's kind of analogous to the frequency at which we see spinal anomalies in our practice, and I frequently tell this to patients when I identify that they indeed have a spinal anomaly in their spine, such as perhaps a transitional vertebra or a spondylolisthesis. I tell my patients that, in the general population, these conditions are rare. But in the chiropractic office, these conditions are common because these conditions commonly are a cause of lower back pain or spine pain in general, depending upon what condition we're talking about. And when people have pain, spine pain, back pain, they come to the chiropractor. So chiropractors are accustomed to seeing these conditions. But anyway, these are just the statistics according to the Agency for Healthcare Research. They found that the most affected age group is between 45 and 64 years of age, with over 51% of all the cases. And females are affected more frequently than males, accounting for about 54% of cases. Now this is interesting because it indicates that between the ages of 45 and 64, and that's a 19-year age span, in that narrow age span, greater than 50% of all cases are coming in. So there's a smattering of cases in people below age 45 and a smattering of cases of patients above 64, with the bulk of cases coming between that narrow age bracket. Further, they found that private insurance was the payer in 41% of the incidences, followed by Medicare with 40% of the incidences, and that reflects the elderly or senior population. And then they found that radiculopathy cases, cervical radiculopathy cases, pretty much were distributed across the spectrum of income and demographic, with 71% of cases presenting in patients whose income was not considered low, meaning that it's not a condition found solely in low-income persons. And additionally, over 50% of the patients lived in large metropolitan cities, meaning that it's not simply something that's related to manual physical labor, or perhaps people that might be in heavy industrial occupations. Even those 50% cases were patients that lived in large metropolitan cities, and presumably, I presume, were involved in what we consider to be white-collar professions. In another study published in the journal Brain, and this was a study that was out of Minnesota, they found that the South was the most severely affected region in the United States, with almost 40% of cases presenting in the South. And they found that the C7 monoradiculopathy was the most common clinical presentation, followed closely thereafter by C6 monoradiculopathy. So let's think about this for a minute. If the C7 nerve root is the most commonly affected nerve root in cervical radiculopathy cases, what does that tell us about the location of the injury or the location of the lesion? Well, that relates to the topic of the relationship of the spinal nerve roots to the spinal vertebrae. And remember that in the cervical spine, the nerve roots are named for the vertebra below the nerve root, whereas in the thoracic and lumbar spine, the nerve root is named for the vertebra above the nerve root. So in the cervical spine, for example, the C1 nerve root lies above the C1 vertebra. Okay, the C1 nerve root lies above the C1 vertebra. In the thoracic spine, the T6 nerve root lies below the T6 vertebra. And similarly, in the lumbar spine, the L2 nerve root lies below the L2 vertebra. So the cervical spine is the exception to the rule, with the nerve root coming out above the named vertebra, whereas in the thoracic and lumbar spine, the nerve root comes out below the named vertebra. Now, there's several different causes of radiculopathy, some more common than others. Causes include, number one, a herniated disc with nerve root compression. And that's probably going to be the most common that we're going to see in a chiropractic practice. And probably going to be the most common one that you would see if you're a qualified medical evaluator as well. Foraminal stenosis due to degenerative changes of the vertebra is another cause of radiculopathy. Degenerative changes around the uncinate joints of Luschka or the facet joints, or degenerative osteophytes on the posterior vertebral body, all can contribute to foraminal stenosis. which could compress the nerve root, so you'll see those cases. Diabetes can cause injury to the nerve roots. Nerve root injuries such as traction injuries and motor vehicle accidents. And typically with traction injuries, we refer to those as stingers or neurapraxia injury. And as this is being recorded in December 2014, you know, almost not even a week goes by without some report of a stinger injury in sports, particularly NFL football nowadays. So those are very common. Motor vehicle accidents can cause traction injuries to the cervical spine nerve roots, although perhaps not quite as frequent as you might have thought of in the past, and I'll go over some statistics regarding that here in just a moment. Scar tissue from a previous spinal surgery can cause subsequent nerve root injury due to perineural fibrosis, and those are common findings. Again, if you're a qualified medical evaluator and you're having the chance to examine an injured worker who has had surgery on his neck. Viral infections can also be a cause of radiculopathy, and the most common of which that you'll encounter in this category would be the shingles or herpes simplex type of viral infection. Now, with regards to motor vehicle accidents, I'm going to reference a study that was published in 2009 in the journal Muscle and Nerve. And what they did was they wanted to determine the frequency of radiculopathy following motor vehicle accidents. And this is a study that came out of the University of Medicine and Dentistry of New Jersey. And what they did was they took 25,000 electrodiagnostic studies, and they divided those studies into two categories. Those people who had electrodiagnostic studies to investigate injuries after a motor vehicle accident, and those who were not in a motor vehicle accident. And they found some of the following statistics. They found that the frequency of cervical radiculopathy was slightly but significantly increased in 8% of the motor vehicle accidents compared to 6% of the non-motor vehicle accident patients. They found that the frequency of plexopathy, meaning either cervical plexus or brachial plexopathy, was significantly increased in the motor vehicle accident cases at 3% compared to the non-motor vehicle accident cases at 2%. They found that the frequency of lumbar radiculopathy was not significantly increased for both groups. Was not significantly increased comparing the motor vehicle accident cases to the non-motor vehicle accident cases. They found that 19% of the motor vehicle accident patients and 18% of the non-motor vehicle accident patients had cervical and or lumbar radiculopathy, and their conclusion was that the frequency of cervical and lumbar radiculopathies is low after motor vehicle accidents. However, motor vehicle accidents do appear to cause a small but significant increase in the frequency of cervical radiculopathy and plexopathy, and that makes sense when you consider the violent nature of your standard cervical hyperextension, hyperflexion injury to the neck, and when you add in the possibility of pre-existing degenerative changes or other types of anomalous conditions that could be present, you can see that certainly with this type of a mechanism of injury, the frequency of neural involvement or neural injury could increase. Okay, so that's a little bit about radiculopathy. What about myelopathy? Well, let's go into some statistics and studies about myelopathy, and I have 3 studies that I want to share with you today about myelopathy and the causes of injury to the spinal cord. And I have for you in your handout materials a 2012 study that was published in the journal Skeletal Radiology. And what they did was they looked at excuse me. They looked at patients who came into the hospital. In this case, this is a hospital in the United Kingdom. They looked at patients that came into the hospital with a diagnosis of myelopathy. Patients who had been diagnosed with myelopathy. And so what they did was they reviewed the clinical case notes and the MRI studies of 41 patients who presented to the hospital with a diagnosis of cervical myelopathy between the years of 2004 and 2008. So this is a small study, only 41 patient study. They found that cervical myelopathy was found to be more common in male patients to the ratio of approximately 2.7 to 1. And that's interesting because with our studies on radiculopathy, we found that the female patients were slightly more affected than the male patients. But here it's the males significantly predisposed to myelopathy at a ratio of 2.7 to 1, with an average age at diagnosis of 63.8 years. They found that multi-level disease was seen in the majority of patients, with the C5, C6 level of the spine being the most commonly affected level of the spine. Now, at C5, C6, if we were talking about radiculopathy, that would be involving of the C6 nerve root. But here we're talking about myelopathy, so that would involve the entirety of the spinal cord from the level of C5, the disc at C5, C6 down. So their overall conclusion was that cervical myelopathy predominantly affects men in their 7th decade of life. It's often a multi-level disease, with C5, C6 being the most commonly affected. So frequently affects men in their 7th decade of life. And that's probably consistent with what you've observed in your chiropractic practice. Another study out of the journal Neurologist in May 2010 talked about the cause of myelopathy conditions. Excuse me, there, I had a phone call. So in another study from the journal Neurologist in May 2010, they looked at the causes of cervical myelopathy, and they found that cervical spondylosis was the most common cause of myelopathy symptoms and myelopathy conditions. And they stated that cervical spondylosis is part of the aging process and affects most people if they live long enough. And in this case, these were people that had lived at least into their 7th decade. So that's when it seems to start to encroach then upon the sensitive spinal cord. They stated that degenerative changes affecting the intervertebral discs, the vertebrae, the facet joints, and the ligamentous structures encroach on the cervical spinal canal and damage the spinal cord, especially in patients with a congenitally small cervical canal. Especially in patients with a congenitally small cervical canal. So what is the normal size of the cervical canal? Let's go over a couple of findings about the cervical canal. And here I reference Yoakum and Rowe, Essentials of Skeletal Radiology. They tell us that the cervical spinal canal is the sagittal diameter measured from the posterior surface of the midvertebral body to the nearest surface of the same segmental spinal laminar junction line. So for example, if we're talking about measuring the sagittal canal at the level of C4, we would measure from the posterior surface of the midvertebral body of C4 to the nearest surface of the spinolaminar line, also at C4. And for those of you that have the PowerPoint presentation, I have here an X-ray image of the lateral cervical spine, and I've indicated with arrows where you would measure the sagittal canal from the mid-posterior body. In this case, I'm indicating the C3 vertebra to the nearest surface of the spinolaminar line of the same segmental level, the same vertebra. Now, according to Yoakum and Rowe, out of the third edition of their text, The Essentials of Skeletal Radiology, average spinal canal measurements range between 22 millimeters at C1 to 17 millimeters at C7, and they consider spinal stenosis to be anything below 16 millimeters at C1 and anything below 12 millimeters from C4 down. And Yoakum and Rowe concludes that spinal stenosis, you can definitively diagnose spinal stenosis at least off of the radiographs when the sagittal canal measurement is less than 12 millimeters. And they state that if degenerative posterior osteophytes are present, the measurement can be made from the tip of the osteophyte to examine the magnitude of the stenotic effect of the osteophyte. And this, of course, is best measured on extension films. In other words, with extension, that osteophyte is going to project posteriorward into the spinal cord, and you can then therefore make an assessment as to the impact of that osteophyte on the symptoms presented by your examinee. And certainly most examinees with cervical spinal stenosis and myelopathy symptoms will tell you that their symptoms are exacerbated by going into cervical extension. So that's how the measurements are made. There is another type of measurement that involves a calculation, and this is called Pavlov's ratio. And Pavlov's ratio is simply the ratio of the width of the spinal canal divided by the width of the midvertebral body. And if that ratio is less than 0.82, meaning that the spinal canal starts to get significantly smaller and smaller compared to the width of the vertebral body, that's indicative of spinal stenosis. And most radiologists consider Pavlov's ratio to be much more accurate and much more diagnostic than any hard measurements obtained on the lateral cervical spine, because Pavlov's ratio removes the effects of radiographic magnification, which of course could distort the numeric measurements that you come up with. The canal to body ratio is going to be the same regardless of any magnification or minification effect of the X-ray images. And then for those of you that have the PowerPoint here, I'm demonstrating to you how Pavlov's ratio would be obtained. I've diagrammed in here the spinal canal measurement. I've diagrammed in the mid-vertebral body width measurement, and then Pavlov's ratio is just the canal measurement divided by the vertebral body measurement, and it should be greater than 0.82. Otherwise, you would be concerned for spinal stenosis. In addition, a 2010 study in the journal Neurologist, they found that patients with myelopathy present with signs and symptoms of cervical spinal cord dysfunction with or without cervical nerve root injury. So I find that interesting that radiculopathy can accompany myelopathy, or myelopathy can present independent of radiculopathy. They stated that the condition may or may not be accompanied by pain in the neck and or upper limb. That would be typically more associated with radiculopathy, correct? MRI is the most useful diagnostic tool, and this study concluded that the effectiveness of conservative treatments is unproven, but of course those of us that are chiropractors know the effectiveness of chiropractic treatment for cervical myelopathy. They found that surgical decompression improves neurologic function in some patients and can prevent worsening in others, but is associated with much risk, and that makes sense. Finally, they concluded that cervical spondylitic myelopathy is the most common cause of myelopathy in adults. So there we have it. 2 studies that concluded that the most common cause of myelopathy is due to cervical spondylosis. So this is something that you're going to quicken your thinking to in your patients who are in their 6th, 7th, and even 8th decade of life, especially the men. And then finally, another earlier study gives us some idea as to some other rare causes and some of the common symptoms that we see with myelopathy. And this comes from an earlier study in 1993 out of the Journal of Neurologic Physical Therapy. And what they did was they studied at autopsy patients who had died with a diagnosis of AIDS. And they found that autopsy studies revealed that 20 to 50% of patients dying with AIDS had a unique degeneration of the spinal cord. A unique degeneration of the spinal cord. And they found that this degeneration of the spinal cord was usually very insidious in its onset. In other words, it came on gradually, imperceptibly slow at the beginning, and for that reason, myelopathy was not clinically suspected. Symptoms included leg weakness, gait impairment, paresthesias, vague leg discomforts, and bowel and bladder incontinence. And because this condition typically occurred with patients who were under advanced immunosuppression medication treatments, the complaints were often attributed to other illnesses and the associated debilitation involved with the disease of AIDS, and then also in receiving treatment for the disease of AIDS. So here we see another rare cause of spinal cord myelopathy. And they concluded that some of the common signs that these patients reported while they were still alive included spasticity of their leg and lower extremity muscles, and then also sensory changes such as loss of vibration and joint position sense. And we're going to get into all of these signs and symptoms associated with both radiculopathy and myelopathy as we continue along here. Okay, so then what are some of the physical examination maneuvers and tests and procedures that are important in assessing radiculopathy and myelopathy? Well, one of the most important tests that we're going to rely on revolves around reflex testing, and this applies to both myelopathy and radiculopathy. So we're going to go over a review of reflex testing and its relationship to testing for both of these conditions. Then we'll get into some specific assessments that are directed toward the myelopathy examination, and then we'll get into some specific assessments that are unique to the radiculopathy assessment, and then we're going to have an extensive discussion of gait, and I'll elaborate much more on gait in the next hour of this program. So we'll review these test procedures first as related to the cervical spine, and then when we get into the thoracic spine, there is not as much examination to be done in the thoracic spine because radiculopathy is much rarer in the thoracic spine than it is in either the cervical or lumbar spine. And really the thoracic spine neurologic exam is much more limited than either the cervical or lumbar spine. However, there are some maneuvers that are valuable and that are quite diagnostic with regards to the thoracic spine. So we'll review some skin reflexes. We'll go over the sensory exam and the thoracic spine dermatomes. And then we'll talk about some of the signs and symptoms that are associated with thoracic spine myelopathy. And then we'll get into the lumbar spine. And here's where we're going to pick up on more extensive discussion of gait. And I'll make some references to the AMA Guides 5th edition and the permanent impairments that the AMA Guides associates with different gait disturbances and different gait findings. We'll go over some specific examination maneuvers for radiculopathy, including some functional maneuvers such as the heel and toe walk, the repetitive squat maneuvers, and then we're going to go into an extended discussion on the sciatic nerve tension signs, the most common of which that you're probably most familiar with is the straight leg raising test, but we'll go over some other tests as well, including the Braggard's maneuver, Neary's bowstring maneuver. And in all these sections related to the cervical spine, the thoracic spine, and the lumbar spine, I'm going to introduce the concept of examination validity, and I'll introduce to you some of the validity and invalidity findings that you can expect to see in the case of bona fide radiculopathy, both in the cervical spine and in the lumbar spine. And so for each test maneuver designed to provoke a nerve root and thereby cause pain to your examinee, there should be an associated relief maneuver that you can add on to your procedures to assess for validity and for credibility of your examination. Now notice here that our lumbar spine examination is going to be mostly focused on radiculopathy, because if you remember the anatomy of the lumbar spinal cord, you'll realize that in the lumbar spine we're not going to be dealing with myelopathy. So recall that the lumbar spinal cord ends at approximately the L1 to L2 spinal level. And so therefore below the L1 to L2 spinal level we're not going to see injury to the spinal cord. Now we will see injury to the descending nerve roots, which we call the cauda equina, but this is more of a form of radiculopathy than it is myelopathy. And then finally, once we get through all those physical examination maneuvers, we're going to get into our radiographic evaluation and go into our analysis of motion segment integrity, and then also our review of compression fractures. So then let's consider the cervical spine then. How is it that you would expect for a myelopathy patient to present? Okay, so I want you to picture in your mind that tomorrow in your office you actually have a bona fide myelopathy patient come in. Well, how are they going to present, and what kind of findings would you expect to be typical for, first of all, a myelopathy patient, and then second of all, for a radiculopathy patient? So let's talk about that. Considering first the myelopathy patient, classic complaints associated with myelopathy include upper extremity difficulties, especially difficulties with fine motor tasks, and then also lower extremity difficulties involving weakness of the lower extremities. So with regards to fine motor tasks, your examinees may report, for example, clumsiness with buttoning a shirt, deterioration of their handwriting, deterioration of other hand-related tasks involved with their general and normal activities of daily living. They'll probably report some type of sensory disturbance of the upper extremities. Most likely the sensory disturbance is going to be a diffuse hand numbness that's not restricted to a specific dermatome. Dermatomal pain, of course, would be radiculopathy. But in this case, it's going to be not restricted to a single dermatome, but may overlap several dermatomes, several contiguous dermatomes, several non-adjacent dermatomes. With regards to the lower extremities, the recent use of an assistive device or walking aids, such as a cane or a walker, would suggest myelopathy. Occasionally you'll find symptoms with urinary incontinence, fecal incontinence, perhaps urinary retention. These would suggest advanced myelopathy versus recent onset of myelopathy. And so this condition is going to affect the person more or less in their activities of daily living that involve their upper extremities and also their lower extremities. So I want to take you now through an activities of daily living assessment, sort of as an exercise to have you start thinking to yourself about what you would consider to be normal impairment in a person with a bona fide myelopathy versus activities that are apparently unimpaired in a person who is claiming to have myelopathy. And this is going to be my first introduction to validity and credibility issues for those, and I give this for those of you who are specifically involved in medical legal work, whether it be workers' compensation or perhaps auto accident cases or even disability evaluations. I want to introduce now the concepts of validity and credibility. So let's go through some activities of daily living, and the AMA Guides 5th edition gives us a good review of activities of daily living. It's not the only source or the only reference that discusses and describes activities of daily living, but it is a good one and it's a very credible reference. So I want to refer to the AMA Guides Activities of Daily Living, which is found on page 4, and the AMA Guides describes several categories of activities of daily living, and we'll go through these one by one. The first category of activities of daily living described by the AMA Guides is the self-care and personal hygiene activities, and that includes urinating, defecating, brushing teeth, combing hair, bathing, dressing oneself, eating, and other meaning any other activities that are involved with self-care and personal hygiene. So imagine this: you have before you a bona fide myelopathy patient, most likely a male in his 7th decade of life, let's say a 65-year-old male with advanced cervical spondylosis, which is bearing down on the cervical spinal cord and causing injury to sensitive neural tissue, both the descending tracts and ascending tracts. How would that condition affect this individual in his self-care and personal hygiene activities? Would that condition affect his ability for urination and defecation? Well, we already said that you can have difficulties with urinary retention, urinary incontinence, fecal incontinence, and that would be suggestive of advanced disease condition. What about simply the personal hygiene component of urination and defecation and the cleanup involved? Would there be some impairment in that activity if perhaps this person had difficulty with fine motor tasks? Yes, it could. These activities could be adversely impacted. I would consider that to be normal. Well, what about brushing teeth and combing hair? Yes, those are fine motor activities that you would expect normally to be impaired in a person with cervical myelopathy. How about bathing, dressing oneself, and eating? Well, again, those are activities that reasonably could be impaired depending upon the stage of involvement of the myelopathy. The next category of activities of daily living described by the AMA guides are the communication activities, and that involves writing, typing, seeing, hearing, speaking, and other. So let's think about this. Well, seeing, hearing, and speaking probably you would not expect to be impaired in a myelopathy cases. Seeing, hearing, and speaking, those are all activities that involve cranial nerves versus cervical spinal cord, correct? So probably those are activities that are going to be spared. But writing and typing, because both of those involve fine motor tasks, you would expect that writing could be impaired, typing could be impaired, text messaging could be impaired, emailing could be impaired, use of a telephone could be impaired, and I would expect all of those to be reasonable complaints. Okay? So we're going through these activities of daily living as an exercise for you to think about what you would consider to be normal findings in a person with a bona fide myelopathy. And many of these activities, because all of them involve either the upper extremities and or the lower extremities, which we're going to get to in just a moment, it would be reasonable to expect some impairment. So that brings up the opposite side of the coin, and that is if you see a person who claims myelopathy symptoms but does not have impairments in activities of daily living involving the upper extremities or involving the legs, it would raise your suspicion as to perhaps the possibility of symptom magnification or some type of non-organic symptom complex. Okay, the next category are the physical activities such as standing, sitting, reclining, and walking. How would you expect myelopathy to affect a person with their ability for standing? Well, standing could be impaired, correct, due to leg weakness and leg incoordination. How about sitting? Probably not so bad. How about reclining? Probably not so bad. How about walking? Probably you would expect to see some impairment with walking. Perhaps there would be the need for an assistive device, such as a cane, such as a walker, such as an ankle-foot orthosis. You would expect this person to have some difficulty with elevations, with steep grades, possibly with getting out of a deep chair. Okay, so all of these would be considered normal findings in a person with myelopathy. They may not be normal for you and me, but they would be normal findings for a person with myelopathy, and therefore, in the absence of these findings, perhaps the diagnosis of myelopathy would need a second look. What about sensory functions, including hearing, seeing, tactile feeling, tasting, smelling, and other? Well, of those, probably only the tactile feeling would be impacted by myelopathy. Next category is non-specialized hand activities of grasping, lifting, and tactile discrimination. And certainly any or all of those could reasonably be expected to be impaired in a cervical myelopathy case. Travel activities such as riding, driving, and flying could be variably impacted depending upon the situation. Probably driving and manipulating the steering wheel and gear shifters and turn signals and knobs and buttons would be the most impaired of these particular travel activities, but again, it would depend on the particular case. The next category of activities of daily living are the sexual functions, such as orgasm and lubrication in females, and ejaculation and erection in males. And certainly those functions could be impaired, particularly with cervical or thoracic myelopathy. And finally, the activities, the sleep activities, such as the ability to get a good night's sleep, the ability to have a normal nocturnal sleep pattern, and the necessity for having to take a nap during the day. All of those, I guess, could reasonably be expected to be impaired in a person with myelopathy. I mean, I can probably think of a scenario where a person with some paresthesias in the hands and legs due to myelopathy might be awake at night with discomfort and pain, and kind of like the restless leg syndrome, you know, it keeps you awake at night. And so these people could possibly report some loss of sleep due to pain and paresthesias that would therefore require them to catch up during the day with a nap, or perhaps take some sleeping medication at night to assist with sleep. And so the whole purpose of this exercise is for you to start thinking about how you would expect this person to present in your practice, and what types of symptoms and impact on their activities of daily living you would expect them to report, and which of those you would consider to be consistent with the condition, and which of those would you consider to be perhaps not consistent with myelopathy.
Okay, so as we've seen, radiculopathy refers to injury to one or more of the spinal nerve roots, and that can be either unilateral or bilateral, whereas myelopathy refers to injury to the spinal cord itself. And there can be many different causes for both radiculopathy and myelopathy. Now it's interesting because the spinal cord itself ends at around the L1 level, L1 vertebral level of the spine, so we don't really refer to lumbar myelopathy because there's no spinal cord below approximately the L1 level of the spine. But as we know, there can be various conditions that affect the descending spinal nerve roots from the lumbar spine, also known as the cauda equina. But this represents a form of radiculopathy versus myelopathy in the lumbar spine. So in the lumbar spine, we don't refer to myelopathy. Myelopathy is constrained to the cervical and thoracic regions of the spine. Now, in clinical practice, in addition to radiculopathy and myelopathy, what you're going to see probably even more common is a condition that is referred to in the AMA guides as non-verifiable radiculopathy, non-verifiable. And what that means is that the radiculopathy is not verifiable by physical examination procedures. In other words, reflex testing is normal, sensory testing is normal, motor strength is preserved, and yet the examinee, the patient, reports pain seemingly in the dermatomal distribution of a specific nerve root. However, physical examination and even diagnostic testing, such as electrodiagnostic testing, are all negative for radiculopathy. So this is referred to as non-verifiable radiculopathy. Now, in your clinical practice, you're going to see these types of cases all the time, non-verifiable radiculopathy, and you can simply treat them as a form of radiculopathy associated with the same specific nerve root. And finally, remember that radiculopathy is going to present as a lower motor neuron lesion, whereas myelopathy is going to present as an upper motor neuron lesion. So they each have their own classic and characteristic symptom manifestation and physical examination presentations. And we're going to go into the physical examination of both radiculopathy and myelopathy in our very next session. So I look forward to being with you shortly.